Hi, everyone. It's such a pleasure to welcome all of you to this RET-positive lung cancer webinar with a group of esteemed panelists. And for those of you who don't know me, my name is Dr. Rupal Vasuroy, and I am the Executive Director of Research at Longevity Foundation. And before we get started and I ask our panelists to introduce themselves, I had a couple of housekeeping things to share with all of you. First of all, please use the comments in the chat function in Facebook to ask our panelists questions, and we will do our best to get through all of the questions. And in case we don't, we will get back and answer those questions on Facebook, so you'll have responses available. This webinar is also being recorded, so in case you miss it, you can come back to our Facebook page and watch it. It's going to be always there. And my last housekeeping comment is to make sure that we keep in mind any information provided during today's discussion is purely for educational and informational purposes and cannot be construed as medical advice. If you learn something that you feel is important for your situation, we encourage that you have a discussion with your oncologist. And without further ado, it is such an honor and a privilege to introduce our three wonderful panelists today. And I'm going to first ask Ms. Umaima Salus to introduce herself.
Hi, I'm Umaima Salus. I'm here because I was diagnosed with lung cancer in 2020. I was 42 at the time. Um, and Shortly after my diagnosis, I started searching the web for information about this rare cancer. My search took me to longevity, and that's how we started working together.
Thank you, Umaima, again for joining us. Now I'm going
Mhm.
to ask Dr. Hilary Hamill to introduce herself.
Hi, I'm Hillary. I have been also living with stage 4 RET-positive lung cancer for the past 3.5 years, diagnosed at age 37, totally healthy, totally turned my world upside down pretty much. And it's been a roller coaster ever since, but I'm here. I'm still here. I'm living a good life, and I owe that to research. And I'm also part of the RET-Positive organization as a board member. And RET-Positive very much it's cornerstone of our organization is to support research and awareness among the RET community of research and this disease. So I'm so happy to join you all today. Be with you, Upal, and John, and Umaima for this wonderful discussion, and everybody who's tuning in. I'm grateful for that.
Thanks, Hilary. And both Umaima and Hilary mentioned finding patient groups, finding RET-positive, finding longevity, and RET is such a rare cancer. It's incredibly important to find your community and find that kinship. And last but not least, I'm going to ask Dr. John Heymach to introduce himself, though he doesn't need an introduction to our community.
Hi, I'm John Heymach. I'm the chair of thoracic head and neck medical oncology at MD Anderson Cancer Center, and been treating lung cancer patients for about 25 years now. And I just want to start by expressing my gratitude to longevity, but also to the others on the call for their support for RET research, because when we're trying to develop treatments for a subgroup like this, we're seeing the patients. We desperately want to find ways to develop better therapies, but it's hard to get governmental funding sometimes for rare subgroups because they're focused on the bigger populations, especially as grant funding gets more competitive. They say, well, why should we focus on a narrow group? And so it's really motivated groups like RET-positive and Happy Lungs and supporters like Umaima and others are really what enables us to put together research on RET, and that builds. Once you've got a core of RET researchers, good things will happen from that. So thanks to Longevity and the others on the call for helping kickstart the RET research community.
Thanks so much, John, for bringing that up. And Umaima, who represents the Hamui Foundation as well, and Hilary from the RET-positive, they are funding a lot of RET research. And here are two patients representing the community funding RET research. And to John's point, funding is finite. So everything and anything that we can all do jointly to advance the field is incredibly critical. So today's discussion, we'll talk a little bit about Dr. Heymach's project, and Dr. Heymach is supported by a grant from the Hamui Foundation. We'll talk a little bit about his project, about what's next in the RET space, and about new treatments. But before we get into that, I'm going to ask Umaima and Hillary to share a little bit about their initial treatment journey, how they were diagnosed. And Umaima, if we can start with you, what your diagnosis looked like, and what was your first treatment, and what treatment are you on right now?
So when I first got diagnosed, the treatment that I started on was Keytruda. I stayed on it for, I would say, 4 rounds, and that didn't work. Then we were about to switch to chemo, and that's when I was able to find a trial near me for the Retevmo, and I've been on it since then.
Thank you, Maimo, for sharing that you were on immunotherapy when you started or when you were diagnosed. And that's a key point that we should keep in mind. And I'm going to bring that back to Dr. Heymach in a bit. But Hillary, let's learn a little bit about you and what your diagnostic and treatment journey looked like.
Yeah, well, it was quite an ordeal. I won't go into the weeds, but essentially we found a suspicious lymph node above my collarbone. And I was healthy at the time. I really didn't have any sort of red flag symptoms until we found this lymph node. Maybe I felt like I was more stressed or fatigued because of the time of the year, or maybe post-COVID. But by and large, when that popped up, I thought, oh no, this cannot be good. And I have a healthcare background, so I knew that a lymph node right above the collarbone is not a good location for a lymph node. So I got in pretty quickly. One bad scan led to another, and eventually biopsied that lymph node. It did confirm that I had stage 4 cancer, and my world was totally turned upside down. And then not to go too thick into the weeds, but I think it will lead into further questions down the road about how, I came across RET-Positive and how important RET-Positive was for me. The tissue of my cancer was a neuroendocrine carcinoma, and neuroendocrine carcinomas can occur anywhere in the body, and they couldn't tell when they looked under the microscope where mine was coming from. And the problem with that is treatments historically are guided based off the tissue of origin. So if you have lung cancer, you have lung cancer treatments. If you have thyroid, breast, etc. And so for a month and a half, I was in this like limbo where we didn't know what type of cancer that I had and how to treat it. And then finally, I was fortunate enough to have next generation sequencing, comprehensive next generation sequencing of my tumor, which showed that I had a RET fusion, and that was the beginning of me finally having hope that there were these brand new treatments, targeted therapies that were just approved, and that maybe I would be a good candidate for that. And so yeah, that was part of my journey, and why RET's so important to me is it was really the only thing at the time that seemed promising to target.
Hillary, thanks for sharing that. And I think you bring up a couple of very important points. First is how important biomarker testing is for all people diagnosed with lung cancer, because that's what can help identify a biomarker that can be matched to a targeted treatment. And you also brought up an important point about neuroendocrine cancers, and we'll revisit that in a bit. But before we get into the weeds, Dr. Heymach, now let's talk to you a little bit about the current RET drugs. Umaima mentioned that she was on a clinical trial for selpercatinib, and there's another RET drug, pralsetinib, and that's what's typically prescribed nowadays. How does your research sort of pertain to these 2 drugs right now that are being used, and what's keeping you up at night? I know that's a very loaded question.
No, that's right. Well, thanks for that question. And the first thing to say is I think our 2 approved drugs for RET fusion lung cancer, selpercatinib and pralsetinib, are both really good drugs. They're wonderful drugs, and I think they're both highly effective. They're more similar than alike. There are some subtle differences between them, but but we're lucky to have, two good drugs. By the same token, we also know that that on the average, they don't last forever in terms of their effectiveness. And so, we typically are tremendously encouraged. We start using them, the tumor shrinks. And then people want to know, well, how long is it going to stay down for? And the answer is, we don't know in a given case. We don't usually get rid of 100% of the cancer cells. We may get rid of a lot of cells. We may get rid of 90 or 95% of the cancer cells. But when you're starting with, 20 billion, 30 billion cancer cells, well, if you get rid of, 95% of them, that still leaves about 1 billion cancer cells. So what I lose sleep over is those billion cancer cells that are left behind, and say, okay, they're up to no good. That's going to be the future source of resistance that's going to emerge. And, so the cells that are left behind, we call those DTPCs, drug tolerant persisters, meaning they're cells that, the RET inhibitor just couldn't kill. And here we learn a lot from other tumor types and other mutations. So in lung cancer, for example, we've learned a lot from EGFR mutant tumors and ALK fusion tumors, where we've learned some of the characteristics of those DTPCs. So most people eventually do have their cancers grow, but in some cases it's many years. In some cases it's indefinite, but in some cases it's only a shorter period of time, a year or less. So first of all, could we predict who is going to have their cancer grow earlier? And secondly, if the cancer does start to grow, can we figure out why it's going to grow? So the way, if people want to imagine this, you start with, a big tumor, and then it shrinks down to a tiny amount. Sometimes we can't even see what's left behind, but those cells are still out there. And then those cells are sort of in hibernation or sort of, hiding out. And then eventually they start growing again. Well, first of all, can we pick them off when they're hiding instead of waiting until they start growing? And then secondly, when they start to grow, how do they overcome or develop resistance to these drugs, selpercatinib and pralsetinib? Now, there isn't one answer to this. We know there's a lot of different ways the tumor can become resistant. But instead of throwing our hands up and saying, oh, we can't predict anything, what we can do is say, okay, well, let's try to understand every possible way the tumor can become resistant, and then develop different strategies when they arrive. And we don't want to wait until that happens. We don't want to be saying, boy, a cancer grew, look how it became resistant, and now we have no idea how to treat this. Instead, what we'd like to do is really be proactive and say, okay, from studying this from years, we now can name the 20 most common ways the tumor became resistant, and let's develop plans for each of these 20 so that we're not surprised when they show up. Instead, if somebody's tumor is growing, we can say, oh, you've got resistance type number 15, and here's what we've studied ahead of time for this. So that's really the things that keep me awake at night. First of all, how do you target those cells that are left behind? Secondly, if the cancer does start to grow, what enabled it to grow, and can we have strategies in hand ahead of time to try to overcome that resistance?
Dr. Heymach, thank you for beautifully articulating that. I think that's really what's top of mind for our community, right? Can we make sure that this drug works as long as possible, and if the drug stops working, what's next for you? And that really is the basis of the project that the Heymach Foundation is supporting and helping Dr. Heymach's lab conduct. Umayma, I'm going to come to you a little bit and tell and share with our audience what was so exciting about this project. And again, just to share with everyone, Umayma and the Heymach Foundation, they were involved in selecting the grant that they are supporting. What was exciting about Dr. Heymach's project?
So as Dr. Heymach just mentioned earlier, This research studies the persister cells or the tiny hiding cells. Knowing how the persister cells behave will probably allow more predictability. I love Dr. Heymach's approach of being proactive. Tackling it before it takes over. It gives us time to expand treatment options and know what we're dealing with in the case of progression. So that is very exciting.
Oh, Maima, you use the word time. That's exactly it. I think it gives our patients hope. It gives our patients time as these new treatment options are developed. And Hillary, I would love your perspective as well, because I know that the RET-Positive are collaborating with the Hamui in selecting these grants. Anything from your side?
I think Dr. Heymach's work and the work that the Hamui Foundation and RET-Positive and Longevity, we've all partnered together. I consider this research foundational, and I hope it leads to critical infrastructure for future research to be built upon. I'm just really so grateful for everybody involved. It's a huge collaborative effort, and it has. I think the most beautiful thing is it has patients and caregivers at the cornerstone of the research that's important to us. That wouldn't, as Dr. Heymach alluded to, that might not otherwise be funded if it weren't for individuals who care deeply about making this research happen. So just couldn't be prouder.
Yeah.
Thanks, Hillary.
Well, if I could just make a comment here about the
Sure.
contributions that patients can, also make. First of all, what the Hamui Foundation funding has let us do is to say, okay, we could just wait and see for all these patients to become resistant and then be reactive when that actually occurs. But we know that it takes a long time for that to happen. And if you're waiting until it's already occurred, you're already behind the 8 ball. Well, just 2 points. First of all, we work in a very collaborative way, and we work with Memorial Sloan Kettering and Dana-Farber and MGH and many other centers to do this research. And by patients enabling their information to be analyzed through things like registry, for example, it helps us build our data set about what type of mutations occur. But what we've done in this research is, instead of waiting until thousands of people develop resistance, we say, okay, well, let's use some new technologies to really accelerate that process. So there are now new technologies that say, instead of waiting one by one for patients to develop resistance, we can simulate resistance in the lab. We can maybe artificially sort of accelerate evolution and put in literally over 1 million different mutations. So we can put in every possible mutation that can occur, and then study all 1 million mutations and figure out of those 1 million, which ones cause resistance. Now, that is a definitive library, meaning we've looked at every possible one that can cause resistance to each of these drugs. And then we can go back and say, okay, here's the 20 or 30 mutations that can cause resistance. Which ones actually happen in patients? Because some of those may not really, occur. But it's the idea of using the lab to accelerate progress instead of waiting for these things to occur naturally, but also connecting it with that clinical data to study. So we may identify the 20 or 30 mutations that cause resistance theoretically, but then we can focus and say, which of these look like they're happening in patients, and let's focus there first on developing a new treatment strategy.
Dr. Heymach, you're already bringing up some questions in my head, and you use the word mutations and mutations leading to resistance. Can you share a little bit about what types of mutations and what's an off-target, what's an on-target mutation?
Yeah, I can, and thanks. That's a really important question. So first, just to give people the background of what we say when we mean a RET fusion, because there's also RET mutations. There's tumors like types of thyroid cancers that just get mutations. a mutation is a general term for a change in the DNA that happens, and that causes changes in the proteins that get made. Now, you can have what we call point mutations, where just one little spot in the DNA gets mutated. What happens with the RET fusion is a little bit different. There, the DNA actually breaks in two different parts, and part of the RET gene and part of another gene come together. So it's not just one little change, it's a whole break in the chromosome and then a rejoining, and it rejoins at the wrong place. And so that's what makes a RET fusion a little bit different than a RET point mutation. A point mutation would be just one small change there that happens. And here we've learned a lot, because there have been RET mutations that have been identified earlier in other tumor types, and we sort of learned a bit about the drugs there. One point worth noting is when the DNA breaks, it doesn't always join in the same way. So we may say you've got a RET fusion, but the truth is there's dozens of different RET fusions. Because RET, when it breaks, it can join with another gene, and there's different genes that it can join with. So, for example, the most common gene that it fuses with is one called KIF5B, KIF5B. So I'm sure that there's a number of people on the call that have KIF5B RET fusions. Now, even there, they're not all the same, because they can break at the DNA at different breakpoints. So if somebody looks at their molecular report, they may say KIF5B 1512. That joins that describes where in the different genes that the breaks and the fusions happen. There's other genes like CCDC6 and a long list of other genes that the fusions can happen. One of the interesting things that we're studying with the support of the Heymach Foundation is, which drug should we use depending on the fusion partner, right? Because a KIF5B RET may respond a little differently to drugs than a CCDC, RET fusion or one of those other RET fusions as well. But anyway, this is, so having an understanding of what a RET fusion is, I think is helpful for people, because we don't have a great understanding how to tailor our therapy based on the specific RET fusion, but that's coming. And as we're developing drugs, we may be developing them specifically for different fusions. Now back to your question about on-target versus off-target. Sometimes tumors can become resistant just by developing an additional mutation in RET fusion. So for example, let's say you've got a KIF5B 1512 fusion. Well, then you might get another little mutation in the kinase domain. The kinase domain is where these drugs bind to. And because of that kinase mutation, the selpercatinib or pralsetinib may no longer bind to the kinase. An example of one of these might be, for example, the GA10 mutations. That's one common. We've got a list of these different mutations. So in that case, RET fusion is still what's making the cancer grow. We say that the tumor may still be RET dependent, but the drug is no longer working because of this extra mutation. So there, what we want to do is find a different RET inhibitor that inhibits that resistance mutation. And so that's part of what we're studying with the support of the Heymach Foundation, is then saying, okay, what are all this, we call these secondary mutations. What are the secondary mutations that can cause resistance? And then if you're resistant to selpercatinib or pralsetinib, then maybe another drug, let's say the ellipsis drug or one of the other drugs may be effective. I should mention, by the way, there are some differences between selpercatinib and pralsetinib in response. For example, CCDC6 fusions respond better to pralsetinib than selpercatinib. The data supports, but for most of the fusions, it doesn't make a difference. Now, what does off-target resistance mean? Well, sometimes RET doesn't change at all, but a new gene gets turned on. And an example is MET, M-E-T, right? So I know it looks a lot like RET, but it's a whole different gene. MET sometimes gets turned on, and it can sort of substitute for RET. So you can be blocking RET, but the tumor no longer cares about RET because it's got MET turned on. So there you might need to block both RET and MET together. And there you could inhibit RET perfectly, but it won't be enough. You've got to inhibit the second gene that's turned on. Sometimes we call that bypass resistance. So that's a second part of what we want to understand. What are the off-target ways that resistance could occur? Because it might be that we've got a perfect inhibitor for RET, but now we need something different that blocks this other bypass pathway. Now, there's a lot more bypass pathways that can get turned on. We don't understand them all. And that's part of what we want to come up with, is to say, okay, if MET gets turned on, or HER2 gets turned on, or EGFR, or one of these other genes, can we find a combination that can target that also? The last mechanism of off-target resistance is sometimes the cell changes its identity. Now, Hillary mentioned she's got a neuroendocrine histology, right? So that's what it looks like under the microscope. Most RET tumors start off as adenocarcinomas, but sometimes after we block RET for a long time, it shifts to another type. We call that a lineage change, and it can turn to squamous, it can turn to neuroendocrine or small cell transformation. It can undergo something called EMT, that stands for epithelial to mesenchymal transition. In all those cases, it may no longer care about RET. You may need a whole different approach to targeting it because it's a squamous or a small cell or something like that. So, those are the three major ways that tumor can become resistant: on target, off target with bypass, or a lineage change where it changes its whole different shape. And we need to really have strategies for all of them, because all of them can occur.
Thanks, Dr. Heymach. And a couple of things I took away from what you just mentioned. First is all RET fusions are not necessarily the same, that
Right.
they might respond differently to the drugs that we have right now. And there are three ways by which cancer cells evolve and become resistant to our current drugs: off target, on target, and then this change into this histological change into small cell lung cancer. I did want to point out that the Hamui Foundation is funding another project which is looking specifically at the MET gene, and in fact looking at how blocking the MET gene, which Dr. Heymach mentioned as an off-target mechanism of resistance, the Hamui Foundation is supporting another project looking at switching off MET in case current drugs stop working. Again, that just goes to show that we need all of these different approaches, as Dr. Heymach was talking about. Dr. Heymach, we already have a question from the audience.
Actually, if I could just add a comment to you before you ask your question. We do think MET's an important target. There's actually a trial, Tejas Gandhi, I believe, at University of Colorado.
Tejas Patel is actually
Tejas Patel, right? Yes, that's right. At University of Colorado, that's testing a combination of amivantamab, so that blocks both MET and EGFR, with the RET inhibitor. I think that's a very nice trial. So if any, I don't know if it's enrolling right at this moment, but I'd encourage people to consider that. It's actually a combination we had also proposed. So I think that's a good example of targeting bypass pathways, and I like that combination.
And that's exactly the trial that the Hamui Foundation is also supporting. Dr. Heymach, to your question about the different types of RET fusions, we have a question from the audience who talks about the PFKP exon 20 with a RET fusion. And you mentioned CCD6 and KIT5A. Yeah. I've never heard of PFKP. Can you talk a little bit about these other genes that are fused to RET? Or is it just KIT5A and CCD6?
No, there's more than a dozen. In fact, as part of our Hamui Foundation research, we've now artificially synthesized, I think we've got 20 different fusion partner and breakpoint combinations now that lets us do sort of an apples to apples comparison. I don't believe we have that particular fusion that was mentioned there. But let me actually mention what the role is for these different fusions. In most cases, so what happens is RET is normally expressed at fairly low levels and with very close regulation in the body. It actually plays a role in the nervous system, is one of the places. But when it breaks and it fuses with another gene, often that other gene is something that's just expressed at high levels or expressed, it just makes a lot more. So suddenly now RET that normally would be at very low levels is being expressed at really high levels with this fusion. So essentially, whatever was controlling the expression of the fusion partner is now in charge. Whether that's KIF5B or CCD6 or CD74 or one of these other fusion partners. So there's really a large number of fusion partners that can occur. And I think we'd like to understand all of them, but really there's no limit to the number of different fusion partners that can occur. We know that some of them behave differently than others, but most of them so far have been highly responsive to RET inhibitors. I think we'd love to eventually cover all the fusion partners. There are some unique ones out there that have only been seen once or twice. They're essentially sort of somebody's own, private mutation that nobody else has ever seen, or private fusion. And then there's other ones that are very common. Now, you might say, well, why does that happen? Why is KIF5B a gene that's more prone to breaking, and why is RET more prone to breaking? And why those break at the same points? There appear to be in the chromosome hotspots for genes to break. And there's some thoughts about why that occurs, but we see over and over that chromosomes don't just break randomly. They have places where they're more fragile and they tend to break more commonly. And halfway through, the RET gene is one. And then with some of these other partners is another place where it looks like chromosomes break more commonly.
Thanks, Dr. Heymach. And before I go to my next question, I'm going to ask Umaima and Hillary to share any feedback or comments they have based on what we just heard from Dr. Heymach. Why is this colon exciting? And maybe we'll start with you, Umaima.
I'm sorry, could you say the question again?
Oh yeah, I was asking if you want to share any feedback or comments about what we just heard from Dr. Heymach and the amazing work that he's doing, trying to figure out all these different types of resistance mechanisms and how they can help patients.
This is a very, I'm honestly very thankful for this research because it will answer a lot of the questions that many patients usually have right after diagnosis, and as well as like later on, as time passes, questions keep coming up, and like having studies like this help answers many of the questions for the patients. Now when we have answers, we definitely feel better. We feel more safe and we can actually live in the moment, as like everybody tells us, oh, just relax, it's okay, enjoy your time. It's like you cannot enjoy your time if you don't have any predictability. So knowing that there are doctors like Dr. Heymach working on these things proactively and having answers for our questions, it's really puts our minds at peace.
Thank you, Umaima. That's beautifully put. That the unpredictability of living with lung cancer, and then having experts like Dr. Heymach on our side doing research and advancing the field so that we have answers to some of these critical questions that are top of mind. Hillary, I'm not sure if you wanted to share anything from your side.
I would just echo what Umaima said, that these are questions that come up all the time in the community, and we're fortunate to have two drugs that work really quite well and are by and large quite similar in many ways, but it commonly comes up, which one should we start on, or if I show resistance to one, can I go to the other drug? And I think jury is very much still out on that, but I think some of Dr. Heymach's research might shed light on how do we optimize the right drug to the right patient at the right time. And as new drugs get developed, the same premise sort of holds true. So I think, we are seeing both on-target resistance and off-target resistance, and that's a very important topic because very different strategies for targeting both of those avenues. So it's very exciting work, very pertinent work for our community.
Yeah,
Thanks,
like you said, I think Hillary is exactly right. Those are all key questions. Those are ones that we don't have definitive answers to. I think, I think our data suggests, some subtle differences. First of all, pralsetinib and selpercatinib are both very good drugs. So I can't say one is superior to the other in any setting. And I mentioned before the example, CCDC6 is one fusion where it looks like pralsetinib may have an edge, at least based on the data we have in hand, but selpercatinib certainly can be active there as well. But I think part of the research we're doing, if you've got an off-target mechanism resistance, then switching to the other drug is probably not going to take care of it, right? Because if you're turning on MET or HER2 or one of these other genes, the problem isn't the RET inhibitor, the problem is this other gene gets turned on. And I think this understanding these different categories of resistance, if you don't have a group of supporters focused on RET, these are the sort of subtle points you're never really going to get to, because we can be focused on RET and every different fusion, but imagine if you write a grant to the federal government saying, I want to study specifically a CCDC6 RET fusion that's a subgroup of a subgroup. They say, well, no, we've got these bigger diseases we want to focus on, but having a group that's devoted to RET means we can now start really digging into these little details. Little in terms of the number of patients affected, but to us, that's what we're focused on, right? So we can, address these little subtle questions about how do we, for this population that's rare, we can, dig in a way that other mechanisms of support wouldn't let us do. And this is where the RET community can also rally behind research efforts and clinical trials. I can't say strongly enough the importance of participating in the clinical trials, or even letting your, contributing your data if you're, to help us understand, by developing these bigger databases. All that is really, really helpful for focusing what we're doing.
Thanks, Dr. Heymach. I think one of the things that I'm taking away from what you just shared is it's important to do a biopsy and figure out what that mechanism of resistance is if the drug stopped working. And to your point, I think switching from one drug to the other doesn't really help. Dr. Heymach, you talked a little bit about chromosome hotspots, and there's a really interesting question in chat. And this also goes back to a broader philosophical question. When Omaima and Hillary were introducing themselves, Omaima was diagnosed at 42, Hillary at 38, and these are really young people, and the RET community tends to skew very young.
Yeah.
Why is it that we are seeing RET-positive lung cancer in young people? And is it that these mutations happen at a higher rate what are your thoughts behind that?
Yeah, it's a wonderful question, and it's one we don't have a definitive answer for, but I can at least put together some of the pieces here. So naturally, somebody would want to say, okay, is this, did I inherit this? So first, the first answer is, no, you didn't inherit the RET fusion. Almost certainly didn't inherit the RET fusion. It almost certainly occurred randomly. And when I say randomly, in your body, every cell has about 5 billion bases of DNA. And every time a cell divides, it has to copy all 5 billion bases. And it's very good, but it's not perfect. There's an error rate. And even if you make an error, 1 out of 1 million times, that means every time a cell divides, there's 5,000 errors in that cell, right? So even if you do it 1 out of 1 billion times, you make an error, well, that's 5 times each time a cell divides that it makes an error. And sometimes that error will just happen to be at the wrong spot, and you'll get an EGFR mutation or a RET fusion or an ALK fusion. And that one change alone, we think, is enough to cause the cancer. So for the same reason that, you have little kids who get leukemia, it was almost certainly just bad luck that a chromosome happened to break or a mutation occurred at the wrong spot. Now, one question I'm sure everybody's wondering, is this an environmental toxin? Is it the secondhand smoke? Is it the radon, or is it something like that? We don't see any evidence that it's any of those things, because we don't tend to see a clustering. In other words, if it was associated with radon, for example, then areas that have higher radon, like in Utah, you would see a higher rate of RET fusions, and we don't see that. As far as we can see, it appears to be pretty random. Now, there is a predisposition for women, and we don't understand why women are more likely to get it than men. It occurs usually in non-smokers, although it can occur in smokers. So in other words, smoking doesn't prevent you from getting RET fusions. But RET fusions appear to occur at the same rate in the population as smokers and non-smokers. So, and there are more non-smokers than smokers that occur there. We don't see quite the same ethnic differences with RET fusions that we do with EGFR. EGFR mutations occur at much higher rates in Asians than non-Asians, about 2 or 3 times the rate. We don't see that same imbalance there. So we know there are ethnic drivers of these mutations, but we don't quite see that the same way with RET. Finally, it is worth pointing out that you can inherit RET mutations. People may be familiar with what's called the MEN syndromes, the multiple endocrine neoplasia syndromes. And that's where families can inherit a predisposition to get certain types of tumors. And they're rare type tumors like what are called pheochromocytomas. Those are tumors that occur above the kidney, and other rare tumors. But that's not RET fusion lung cancer. RET fusion lung cancer is not typically inherited the way that RET mutations are inherited in the multiple endocrine neoplasia syndromes. So anyway, I know I just gave a very long-winded way to say we don't know why it occurs, but it appears to be by chance. It doesn't appear to be environmentally associated. It doesn't appear to be related to smoking. We don't believe it's related to secondhand smoke as far as we can see so far. But I don't want to give an air of certainty about that because the bottom line is we don't know. So I'm not going to tell you here's the cause.
Dr. Heymach, very helpful. And I know we don't have a lot of time, so I want to pivot a little bit about what treatment looks like today and what's happening in the clinic. And Omaima mentioned that she started with immunotherapy, which is Keytruda, and that worked for 4 cycles, and then she found a clinical trial. Does immunotherapy work for RET-positive lung cancer, the current immunotherapy drugs, and is there a place for it?
Yeah, this is a great question and a very important one. Immunotherapy is a general term for things that stimulate the immune system to attack the cancer. But the ones that are approved right now in the clinic are a specific type of immunotherapy that we call checkpoint inhibitors. So these are PD-1 or PD-L1 inhibitors. These are drugs like pembrolizumab, nivolumab, atezolizumab, ipilimumab, and so forth. These type of drugs, immune checkpoint inhibitors, are not particularly effective for RET fusion tumors. RET fusion tumors tend to have low PD-L1 and low tumor mutation burden, it's called. And so in general, those types of therapies are not effective. Even if your tumor is high PD-L1, it's almost certain that the targeted therapy is going to be better. So I bring this up because sometimes people find the concept of immunotherapy very appealing to say, boy, I really like the idea of the immune system fighting my tumor. I'm going to do that instead of targeted therapy. And one really clear message I want to deliver is targeted therapy should always be the first choice, not immunotherapy for a RET fusion tumor. I can say that unequivocally, even if your tumor is high PD-L1. And I say that because very often there are well-intentioned community doctors who treat all different types of cancers. And that's a huge challenge. I can say that, I don't know what I would have to do. I only treat one type of cancer, which is lung cancer. And that's a lot to keep up with. If I had to treat 20 different types of cancers, I would be a lost cause. In fact, I've got to retake my boards. I have to redo my boards every 10 years for board certification. I've got that coming up in 2025, and I'm going to have to learn about all these other tumor types. And I'm like, worried about that. But anyway, back to the point. So there are docs out there who just, may say, boy, immunotherapy works for lung cancer. I'm going to use immunotherapy. So it's important that everybody knows first choice is always targeted therapy for RET fusions. Now, other types of immunotherapy may be effective for RET fusions. And that's really what we're trying to develop. What are other types of immunotherapy? Well, there are types of immunotherapy called TCEs. Another name for that. So TCE stands for a T-cell engager. If you've heard the term BiTE, a BiTE is a subgroup of a TCE. A BiTE stands for a bispecific T-cell engager. And what those do is you can think of them having a couple arms. One arm binds to an immune cell. Another arm binds to the tumor and sort of brings them together like a forced marriage. So it sort of forces the immune cell to attack the tumor. We are hopeful that we can develop TCEs that could work against RET fusion tumors. And in fact, one of the things we're trying to do is see if we can develop TCEs or other types of immunotherapy to tackle those drug-tolerant persisters, those little ones that are left behind. And we think we have some ideas about how to do that. There's another type of immunotherapy called CAR-Ts, C-A-R-T. That stands for chimeric antigen receptor T cell. And essentially there, what you do, it's a similar idea, but you're taking the immune cell and re-engineering it to attack something on the cancer cell. Now, that's a much more complicated process. It's a much more expensive one, but it's been very successful for lymphomas and leukemias and hematologic malignancies. We're working on developing CAR-Ts that could attack those drug-tolerant persisters for RET fusion tumors as well. So I don't want to give a blanket statement immunotherapy isn't effective for RET. I want to be very narrow and say so far immune checkpoint inhibitors do not work particularly well, but we're trying to develop more effective types of immunotherapy down the road. The last thing, as I mentioned, is we've got a new class of drugs called antibody drug conjugates, or ADCs. ADCs do look like they've got some activity here, and we want to develop better ones specifically for RET. We may see some of those approved, not for RET fusions, but approved in the next year. We may see approvals for datopotamab deruxtecan, which targets TROP2, or patritumab deruxtecan, which targets HER3. That's a class of drugs that we think carry promise for RET fusion tumors, and we just need a little more work to get there.
Thanks, Dr. Heymach. So you mentioned immunotherapy is not at least not the first option. So let's sort of play out the scenario that here's a person who's been diagnosed and they are on selpercatinib or pralsetinib and they're facing progression. Can you talk a little bit about what your clinic discussion looks like today? Is there a place for adding chemotherapy, say, to the targeted therapy, radiation, or immunotherapy at progression? What does that look like in the clinic today?
Yeah, that's a great question. And as you noted in the beginning, I think this is important to have detailed discussions with your doc. But I also think it's important to get a second opinion here at a site that treats a lot of RET fusions, because because of the low frequency of RET fusions, there's a handful of sites that treat a lot of patients. And I'd always encourage people to consider clinical trials in that setting. But the first thing is to obtain molecular profiling. Now, somebody might say, well, what are we going to do with that information if we don't know what to do with it? Why should we get molecular profiling, meaning to look at what new mutations have happened in the tumor? Well, what that can help us figure out is this an on-target resistance? Is it a new RET mutation? In which case, looking for new RET inhibitors would almost certainly be the best option, or trials with new RET inhibitors. Or is it a bypass? In which case, combination therapies may be the best possibility. So, for example, one might say, all right, if you've got a MET amplification as the resistance mechanism, well, go pursue one of those clinical trials, like Dr. Patil's trial at University of Colorado, which I think is a wonderful one. And we've got some new trials that are coming along. Now, chemotherapy is always an option, and chemotherapy would be the standard thing to do as second-line therapy with or without immunotherapy. The way to view chemotherapy is it is active. It's more tolerable than most people think it's going to be. We would usually use carboplatin and pemetrexed, and it's fairly effective, but it's not a long-term solution. It would be very rare for people to get years of benefit from chemotherapy. More commonly would be to get something between 6 months and a year of benefit from chemotherapy, which is great, but I tend to view chemotherapy almost as a bridge that'll keep things going while we're trying to find something that's spectacularly effective, which is what we're looking for. So chemo is absolutely an option, but I'd view that really not as the long-term solution, but really as something that'll knock it down, keep it down, while we're thinking about what's next there.
Thank you,
And
Dr.
I'm sorry, you asked one other question about radiation.
Mhm.
That's a very important question. We like to think of when the cancer starts growing, we like to divide it into two categories. Sometimes the cancer is really exploding in terms of lots of little metastases somewhere, right? You might say there's 20 new tumors in the liver, or there's 20 new tumors in the brain or something. If that's happened, it's going to be important to switch to a new type of systemic therapy. But sometimes it's only one or two spots that's growing. The term we use for that is oligoprogression, meaning there's only one or a few sites of progression. For oligoprogression, I usually try to just knock out those one or two sites with radiation or surgery, get rid of the sites that are progressing, and then if somebody's doing well on selpercatinib or pralsetinib, go back on it, keep it going. There.
Thanks, Dr. Heymach. And I'm going to go back to the chemo question. So you mentioned again, pemetrexed and carboplatin or cisplatin. Do you continue the Retevmo or the Gavreto? Like, is it a combination of the targeted drug plus chemo, or do you take people off the targeted drug and just do the chemo?
Yeah, that's a great question. So what's FDA approved is not continuing the selpercatinib or the pralsetinib. If you sort of look up what is formally FDA approved, well, selpercatinib and pralsetinib are approved by themselves and not with chemotherapy. On the other hand, what do we do? Well, sometimes we consider if somebody's doing really well on the TKI and we just need to knock the cancer down a little bit, sometimes we consider the combination, even though we have limited data for it. Now, this is an area where I wish we had better data. I wish we had more data for it. Part of the reason people like to continue the TKI sometimes is because TKIs like pralsetinib and selpercatinib are better at penetrating into the brain and preventing metastases from growing in the brain. So sometimes we like to keep those on. But I want to emphasize here, we don't have the type data we would like to have to support that that's the right thing to do. So this is, if you ask what's the FDA label say, the evidence is just for chemo by itself, but sometimes we will keep the TKI going.
Thanks, Dr. Heymach. You talked about tolerability of chemotherapy, and I know we are almost at time, but I did want to bring up this piece about side effects on treatment, and that's incredibly important to patients and their caregivers as well, the quality of life on these drugs. And Hillary, I would love to hear from you a little bit about your own experience and what you're hearing from the RET community. What's top of mind from the side effect side?
Yeah, I mean, this is probably the biggest issue that comes up within the community. And I just want to point out, everybody's unique. So I've heard the gambit of people who are on targeted therapies that have very little side effects to no side effects. And there's people that have poor tolerability, can't tolerate the drugs, or can only tolerate a very little dose, which sometimes works very effectively. The vast majority of people are somewhat in between. Of course, RET-targeted therapy can be incredibly manageable, but that doesn't always equate to tolerability, as we know. So that's where having this community and resources from the RET community can be really helpful, because patients, we can help you with the various resources out there. Drug manufacturers have guidelines on how to sort of deal with these certain common side effects like elevated liver enzymes, et cetera. And, a lot of patients tell me that their oncologist, even their, thoracic oncologist or their specialist oncologist, maybe only has taken care of one or maybe even no RET patients before. So I think it's helpful to have sharing of the resources within the community, or even patients saying, you know what, I have this side effect or had this side effect. This is how I got through it, or this is how I managed my side effects. And I think it's incredibly helpful when that was one of the biggest benefits of me when I first knew that I had a RET fusion and I was introduced to the RET positive community. I mean, I was reading about this new RET drug that I'm on, and it sounded awful and scary and really, really bad. And hearing that people were like, nope, I'm doing pretty well. I live a fairly normal life. Yes, I have side effects, but they are manageable, that sort of thing was super helpful for me to hear. And so I think that I think these drugs are certainly not perfect, but can be managed, and there's resources out there.
And Dr. Heymach, what does that conversation look like for you in terms of side effect? How do you approach that in your clinic?
Yeah, well, it's a number of great points that Hillary just made. First of all, I think having groups, like RET positive, where people can talk with other patients, I think is incredibly valuable, because people will always have a certain skepticism, appropriately and understandably, about what the physician tells them, right? Because it goes back to like when you're a kid and they say, this is going to pinch a little bit, and then, you get this horrible big needle stuck in your, backside, right? From that time, you say, okay, we can't trust exactly what they say, or we have to interpret it in that light. So having people who are getting treated, discussing it with other people, I think is an incredibly valuable and reassuring thing for patients. I think it's important to have the separate set of information. I think it's also useful for patients with RET to have physicians who deal with lots of RET patients, at least as consultants, or at least to talk to. That doesn't mean they have to be seeing them all the time, because it's if you're somebody who doesn't treat hundreds of lung cancer patients a year, it's unlikely that you've got any meaningful experience with these drugs, with selpercatinib and pralsetinib. And they're well-tolerated, really good drugs, but they do have some unusual side effects. I'll give you an example of one that we deal with. You can get fluid around the lung, and it's a side effect of these drugs. It's called a chylous effusion. Here, chylous is a weird word. It's CHYLOUS. And this is a particular, it's like lymphatic drainage that occurs there. Now, commonly, pleural fluid could mean that the cancer is progressing. But in this case, it does not mean that at all. And so I've probably had 3 people in the past year that came in and said, oh, it looks like my cancer is progressing. I got all this fluid in the lung. And we say, nope, that's not, or we analyze it, and then we say, nope, that's not the cancer progressing. That's a side effect of the drug, and so because you would otherwise, stop the drug and you say, oh, the cancer is growing, and that's not the case at all. So that's an example, as with any drug, you've got to use it a fair amount before you really get to understand all the potential side effects and so forth. So it's actually a fairly easy drug. Both drugs are fairly straightforward, but they do have peculiar side effects that one has to gain some experience with.
Thanks, Dr. Heymach. And Hillary, thanks for also reminding us that tolerability and manageable are different things for a patient. That just because a side effect is clinically manageable, that doesn't make it tolerable for a patient taking the drug. And I know that we are at time, so I think we wrap up today's discussion, and I'm going to invite Umayma and Hillary to wrap it up for us and share a message of hope for our community. Umayma, what gives you hope, after hearing all of this discussion? What gives you hope?
Living with RET positive for the past 4 years has really taught me to be very grateful. Sorry. It taught me to be very grateful for every day and every minute that I get to be here with my family. At the same time, I'm well aware of the reality that change of pace is always one scan away. I understand the struggle of having to find a peace of mind in a situation that doesn't offer predictability or guarantee of what life will be like after my next scan. Having talented doctors like Dr. Heymach working by our side to create more treatment options and more answers gives me hope, and it keeps me inspired to enjoy the precious gift of time that I have. So thank you very much for joining this mission and working by our side. My hope is that doctors like you will continue to be motivated and inspired to make meaningful changes for the RET-positive community. Thank you.
Thank you, Maima, for that beautiful message of gratitude.
Yeah, I couldn't have said that better. That was beautiful, and I completely echo your sentiments. I'll just add from like an advocacy standpoint, I am absolutely blown away over a short period of time by the collaborative efforts from the Mui Foundation, Longevity, RET-Positive. There's the Happy Lungs Project as well. These have all been collaborative efforts from the RET community, patients, caregivers, who have raised, I think I've counted at least over 3 million directly in research, which is phenomenal. And in a short amount of period of time, with a relatively small group of people have done that. And I think that is just, I hope that's encouraging to researchers. I see this research as, you know, foundational, important infrastructure that can be built upon further. I not only collaborative groups from an advocacy standpoint, but researchers like Dr. Heymach. I'm so encouraged by these researchers who are working with each other, because rare cancers are difficult to study. And so pooling your resources and working with other institutions also is crucial and gives me a lot of hope too. So I think the future research, while there's very unique challenges in RET, I think there's many future opportunities. So I'm encouraged by that.
Thank you, Hillary. And I think that's the perfect way to end today's discussion. Gratitude and for Dr. Heymach, gratitude for Umaima and Hillary and all our advocacy groups who are taking charge of RET research, and gratitude for collaboration. I think that's what really drives the field. And before I really end, I did want to tell everyone that today is Hillary's birthday. So if you see her, give her a big hug or send her a wish over Facebook. And a big shout out to Dr. Heymach. In fact, he's in Washington, D.C. right now for a meeting with the FDA and Longevity to tell the FDA how to make better clinical trials that are important for patients and align with their reality. So again, lots of things to be grateful for. And thank you so much for joining us. Take care.
Thank you.
Thank you so much,
So
everyone.
good to see everyone. Thank you.
Thanks so much. Bye-bye.
Bye.